Dr. Morse, one of the issues that comes up in questions that we hear is that some people understand that their child has epilepsy, but they don't necessarily know that that's a seizure disorder, or vice versa. And so primary care providers might have to give an explanation to families to understand where those two things come together and how they might be different. Can you give us a little guidance on how they might be able to share with families that information?
Sure. I think it goes back to definitions, and obviously a seizure is defined as hypersynchronous or excessive neuronal activity in the brain, in a part of the brain. So there are the phenomena of seizures, and then if you have a string of them, you have epilepsy. So a string or a recurrent unprovoked seizures. Epilepsy and seizure disorder might mean the same thing in many cases, referring to the fact that it's a condition of spontaneous recurrent seizures. When different people use the term epilepsy, they refer to more than just the occurrence of seizures, but who's having the seizures, what the setting is, what the age is, what the EEG looks like, and kind of add some other facets to the story that would perhaps help in deciding which medication, what the prognosis might be. And so the term epilepsy would more likely refer to consideration of those other things than just seizure disorder, which would refer to the fact somebody has recurrent seizures. They can be used interchangeably, though, for practical purposes.
Can you give us some guidance to pediatrics in terms of when to refer a patient if a parent has a question or school has a question about whether a child is experiencing an absence seizure or whether it might be ADHD, an attentional issue?
Oh, that's a good one, because I think every week or twice a week we get a referral for that very question. And it's usually the diagnosis of ADHD that's been floated, and then there's some observation on the part of the teacher or someone else that says, well, maybe not. And I think the clinical features are greatly overlapping, but they also do differ once you tune into the observation of the event. Seizures, absence seizures, which is also called a petit mal type of seizure, usually consists of a behavioral arrest, a staring spell, be it brief, with unresponsiveness during that time, and then a return to normal baseline. They usually occur many, many times a day, and they're usually very brief, not prolonged. An attention deficit disorder child may have staring spells, may have moments of not being fully responsive, but if you look closely, they won't have the same look, the look that you can see on a child with an absence seizure. So clinically you can tell sometimes them apart. Sometimes you need an EEG to tell them apart, and the EEG in the case of absence has a very high yield. It would detect about 80% of the time if a child is having absence seizures versus an ADHD appearance. A string of absence seizures which do interfere with a child's ability to pay attention and register information can certainly look just like an ADHD profile, a child who appears to not understand and is asking what all the time. And again, it can be hard to tell clinically, but I think if there's any question that the spells are briefer, they're occurring in the middle of eating or doing some other activity as opposed to perhaps a moment where you just are caught up in something else and is more innocent in that sense. If it interrupts something, particularly the child likes doing, then you'd have to suspect seizure as the basis for it. The brevity of them can help because usually absence are quite short. If you look closely, most kids with absence will have something about their eyes, either a little rolling upward or a little flickering of their eyelids. And again, that can help differentiate clinically from ADHD.
In the past, we've heard you talk with some providers who've had this question, and you shared a little office trick about eliciting a response with hyperventilation.
Yeah,
Can you share that?
Absolutely. Hyperventilation, which is just having the child pretend to blow out a giant birthday candle or huff and puff, but at a slow rate, just very deep breaths filling up their lungs. For 3 minutes, to 4 minutes will reliably provoke an absence seizure in the vast majority of kids. So if you can get them to just sit on the exam table and start breathing and time it, have the parents watch with you, and before long you will probably see a seizure. And the important thing during that seizure is to test their responsiveness so that you give them an empty phrase, 3 purple dogs, 5 yellow bats, and then when it's over say, did you remember what I asked you to remember? Again, it's a useful indicator that they're probably in an absence seizure if they don't remember. And the ADHD kids don't have spells provoked by hyperventilation and certainly would remember if you said something to them during it.
One of the things that primary care providers have to deal with quite a bit is the issue of febrile seizures and the difference between simple febrile seizures and complex febrile seizures. Can you help to describe what that difference might be and whether there's any differences in the management for those patients?
Okay, that's a good question. The definition of febrile seizure, be it simple or complex or complicated, comes from old data that looked at thousands and thousands of children. And what discriminated the two was the duration of the seizure, the vocality of the seizure, or the repetitive nature of the seizure within a given febrile illness. So if you have any of those features, seizure longer than 15 minutes, which is historically derived data, but it was 15 minutes, focal, meaning part of the body's involved, not all of the person at the time, and if it's repetitive within a given illness, more than one seizure within a 24-hour period, then you have complicated or complex febrile seizure by definition. The opposite of that, short seizure, non-repetitive, generalized, is a simple febrile seizure. Complicated febrile seizures account for about 1/3 of febrile seizures, and the complexity factor carries with it some weight of identifying those who may have an increased risk of epilepsy, not just simple febrile seizures that don't carry much of an increased risk at all. So if you're in the office and you're addressing a child with a febrile seizure, getting a description of the seizure, the duration, the repetitive nature of it, identifying it as complex or complicated versus simple, would then sort of tell you what to do. And the next step in complex febrile seizures, because a certain subset of those kids will have underlying lurking epilepsy, not yet manifest as afebrile, we would recommend getting an EEG on them as a screening test. Other than getting an EEG, because a fair number of kids do have complex febrile seizures and don't go on to develop epilepsy and just have febrile seizures that's outgrown, we don't recommend treating or doing anything differently, just the screening EEG. If it identifies a problem, then you'll go on a little further. If it is normal, which most will be, then they would be treated the same as other children in terms of recurrent febrile seizures are offered preventive measures, but otherwise you're not placed on any anticonvulsant.
And would it be a advisable recommendation that for primary care providers who have identified a complex or complicated febrile seizure in a child that they incorporate a fever management component to their care plan?
Absolutely. I think the vast majority of kids have 1 or 2 at most febrile seizures, so they're not going to be, and the biggest risk factor for that is their age of onset. So if they're 12 months old, they're very more likely to have another febrile seizure. But you have to anticipate that they might, and it would be good for parents to know how to respond and what to think of. So if anyone's had a febrile seizure, be it simple or complex, having a plan, a management plan for handling fevers is a good idea. Complex, perhaps a little more than simple, but I think in both cases. Just to kind of cover the span of age, the febrile seizures peak at around 16 months. They can begin as early as 6 months, and they can last as long as 6 years in terms of the vulnerability or propensity to fevers causing a seizure. The vast majority peak at 16 months, and by age 2 are outgrowing it, so it's a kind of a big peak in the 14 to 24 month range that covers about 80% of them. So if you get to age 2, 2.5, you're getting to the point of less and less chance of having more febrile seizures.
That's good to know.
Do family factors play any role in the likelihood of whether a child who experiences a febrile seizure, is there a higher likelihood if a parent has experienced them or siblings?
No doubt about it. There's genetics that play a huge role in febrile seizures. They do affect about 5% of children, and the vast majority of time, if you take enough of a history, you'll find there is a family history. Mostly it's got a pretty much autosomal dominant inheritance pattern, but it hasn't yet had any one gene, one condition. It's probably more susceptibility genes that are inherited and predisposure during this developmental period of brain to febrile seizures. But yes, there are strong genetic factors.
So it would be an important question for primary care to ask in terms of a first event for a child, whether or not other family members have experienced a febrile seizure?
Yes, important and reassuring, because if it's just in the family, you can sort of refer to how well others have done or how they've outgrown it and reassure parents.
Can you talk to us a little bit about Diastat or midazolam, the emergency medication? Which patients for whom seizures are diagnosed do you prescribe them for?
Diastat and midazolam are benzodiazepines, and they're used as emergency rescue medications to stop a seizure before it goes on too long. Generally, given the new definition of status epilepticus, which means an enduring seizure state, we ask parents to be prepared to administer, or caretakers to be prepared to administer the medication at 5 minutes. Diastat was sort of the original one product that was on the market and came out. It's rectal, it's preloaded and pre-dosed with really easy administration. It's portable, comes in a kit of 2 and can go with the child, and one can be at school, one can be at home. We generally prescribe an emergency rescue medicine to pretty much everyone, because if you have a diagnosis of epilepsy, particularly in the beginning, when you first start medication, you don't know whether it's going to completely control it or not, and you don't know how much the dose is going to need to be to control it. And there's always the risk in anyone who has epilepsy throughout their lifetime of status epilepticus occurring, be it triggered by getting ill, run down, or some other factor, or just spontaneous. So because that risk is there, we pretty much always think about what if an emergency happened and make sure that there's some plan to address it. Practically speaking, the people we don't prescribe it in are really ones who we think the risk is pretty low and the medicine is really expensive. So if we don't think you're really ever going to need it, then it becomes we weigh it, especially if the parents are close to help. In terms of midazolam, that's a nasally administered medication, and obviously for the teenagers particularly, it appeals big time over Diastat, because they imagine themselves having a seizure in the cafeteria and having to go through the humiliating experience of having their pants pulled down. And I think that's very understandable. Usually by the time you're getting Diastat, you really don't know where you are or what's going on, but it's hard to convince someone of that. And midazolam is very easily administered. It's a liquid, it's sprayed up the nose through an atomizer device, and it works as well, clearly, as Diastat. The problems with it really are only that someone has to draw up the dose at the time with a non-shaky hand, transfer a needle to from the syringe, take it off, put the atomizer on, make sure it's secure enough that it's not going to pop off when you put the little pressure on the barrel of the syringe. And other than that, it's easy, it's portable, and I think is gaining more widespread application and usage. It's not yet approved for that purpose and hasn't been studied as extensively as Diastat. So there's a certain body of evidence that doesn't support it as much as Diastat. But I think that's just a matter of doing a study or two, because it's clearly as effective.
And in terms of the administration and sort of guidance for families and other caregivers, how are those components incorporated into seizure action plans for individuals?
Okay, well, the seizure action plan is really a nice way of getting everyone on the same page, having a document that anyone can read, have access to, hopefully, in the case of an emergency, how to approach a seizure, particularly a prolonged one. And anyone can read it, anyone can use it, and particularly with Diastat going with the person who has the epilepsy, that person may not always be in parents' keeping or under the care of someone who is known to that person. In schools, basically the nurse of the school can administer it, or anyone who he or she designates as a person and trains them in how to use the medication. So it's more favoring having a good support net for the safety of the child in terms of who can administer it. And we'd like to have universally everyone be able to administer anyone for the case of the emergency. And I think the use is very easy. There's a 1, 2, 3 steps. We advise all parents to read the cartoon description of how to do it before they have to do it, because in the event of a panic mode, it's actually surprising to say, oh, I never read the directions. So it's nice to read them ahead of time and be prepared. But I think that it figures into the action plans as the first line of defense or the first response for an emergency. And that would be a seizure more than 5 minutes.
One of the exciting components of research that is happening right now related to epilepsy is looking at the connection between cortical focal dysplasia and human papillomavirus, particularly in relation to the impact or the potential impact of vaccinations and prevention of certain types of seizures. And I think that's very exciting. Could you help us to understand a little bit more what that connection might be and what the potential in the future is for understanding that?
Yeah, this is one of the more exciting developments to come along in a while. A few months back, there was a publication by some researchers who had looked at the occurrence of human papillomavirus, which is the most common cause of cervical cancer, and its tendency to express a certain protein that will affect brain cells in terms of their migration and formation of the brain. The group demonstrated that this protein was being expressed in a number of surgical specimens from what's called focal cortical dysplasia, that being a little area of tangled nerve cells in the brain, and that being one of the most common causes of focal epilepsy in children in the era of MRI, when we can actually image the brain and kind of look at how it's constructed to pretty exquisite detail. So they asked the question, what does one have to do with the other? One being common, the other being common. Not so common in terms of the brain malformation, but a pretty common cause. And they took specimens from brains and human specimens and stained them for these protein markers that would give evidence that the virus had been there. And they found in 30 out of 30 specimens of focal cortical dysplasia removed at surgery evidence for the HPV virus. In an equal number of control specimens of brain removed for other reasons at surgery, they found none of it. So this was a pretty compelling finding. They went on to look at a mouse model where they actually brought this organism, this virus, in and saw what effects it would have on the development of mouse brain, and they reproduced, in fact, cortical dysplasia in the mice brains. So it's an early and not fully established, scientifically these links are always made slowly, and someone makes an observation and then everybody has to prove it and strengthen it, but it seems like a pretty interesting notion that HPV, human papillomavirus, might actually be affecting the development of babies' brains and leading to cortical dysplasia and epilepsy. The real exciting part of it would be if it's true and confirmed that there's now a vaccine against human papillomavirus available, and if a girl or a boy were to receive that vaccine, in this case a girl probably, but I think they recommend universal vaccination at this point, were to receive the vaccine, then the human papillomavirus would not be able to both cause cervical cancer, but also presumably transfect a developing fetus and cause cortical dysplasia, which would make this odd connection between preventing a virus from establishing a foothold and preventing epilepsy, which is a really interesting twist, but I think a very exciting one. And it opens a lot of thoughts up about how we might approach prevention of epilepsy.
And just as a quick follow-up, so people know what numbers we might be talking about, what percentage of childhood seizure disorders are related to focal cortical dysplasia?
Well, it'd be hard to get an exact number. I can say that if you take all children with epilepsy, you know that about a third of them won't respond to medication. So of those third that don't respond to medication, about a third are surgical candidates. And of that third, which is now a ninth of the total, who are surgical candidates, there's probably 60% are cortical dysplasia as the basis for their surgery need or their epilepsy. So it's pretty common.
Great.
Yeah, I mean, I have a biased point of view, but it's pretty common.
It's just an exciting sort of area of research.
It's incredibly interesting, and I think is probably going to be a true finding.
That's great.
Yeah.
Can you give some guidance to primary care providers who might be seeing a patient or sharing a patient with you who's been newly prescribed an anti-epilepsy medication in terms of what they should be thinking about when they see that patient on a next visit, or screening for, asking in terms of side effects or changes that the parents or the patient may be able to identify since they started on this medication?
Okay, that is a very important part of the team and the management, the co-management of anyone with epilepsy who gets started on a medication, in that the primary care provider has the opportunity to look, well, certainly so do we, but to look at the whole picture and see the child in his or her environment, school, home, all those aspects. And I think the treatment of the seizures is only one part of treatment with an anti-epileptic medication or anti-seizure medication, in that they may do quite well at stopping the seizures and controlling them. That's great. That's what we want. There are a whole number of other considerations that we don't have as well studied and we don't tend to track as well, which would refer to the comorbidities of having epilepsy. Comorbidities of having epilepsy meaning the school performance, the mood, the quality of life, the other aspects, and the effect on the family of having a child with a chronic condition to begin with, so, and the community. So I think the primary care provider has every opportunity to ask about a lot more, and should be asking a lot more than just any seizures, how are you tolerating the medication. That's important as well, obviously that's the primary goal. But the other sides of it are a little trickier, a little less easy to have a body of data that says this will be so, but I think also very rich in terms of looking at how the adjustment goes forward. And I think the school performance is one big one, because the effects of anti-seizure medications on cognition, on thought and processing are still understudied, but it's clear we don't get away without any effects, and we can't just say that's not an issue for many children. For many it seems to be fine, but for many it isn't. And I think that looking at that and at least asking about it, asking about quality of life, about the strange things that people may do, because some people get so spooked out by epilepsy that they'll bring their children into bed with them, and they'll get monitors and alarms, and they'll get sleep deprived beyond belief, worrying over the seizure they might miss. So there's a lot to know about epilepsy that would help manage patients with epilepsy, and there's a lot of considerations of the rest of their life. Most every patient will have sooner or later a question about, managing the medicine, forgetting a dose, mixing it with other things, reproductive health, all those questions that do come up and are important, as well as mood. And I think it's not completely on the PCP to have to do all those things, but they're in a good position to keep, as part of the team, that conversation going. Yeah. And just one more thing I would say to the primary care providers: don't be afraid of all these numbers of medications that are used to treat epilepsy. Get to know them. They're really not as daunting as they seem, and getting the experience and the comfort in managing them, getting to know what their particular side effect profile might be, really will help the whole situation, and can be something the primary care provider expects of the neurologist if the child's going to a neurologist, in terms of really having an educational part to it whenever a new medication is started. So for the specialists, it really is important for us to include some discussion about the medication for the primary care provider to feel like they understand it and know it a little better. But for the primary care provider, don't be afraid of the medications. They really are wonderful, and you can get to know them pretty easily.
I did have a question in terms of guidance for primary care providers. We've been talking about some of the issues about side effects and changes, some of the health and wellness issues, even some life changes, developmental changes that might be taking place with puberty. How would you recommend that PCPs identify those times when they really want to refer back, even if an individual is well managed, to the neurologist to answer some of these questions, versus when maybe it could be something that the PCP could talk directly with the specialty provider with to do some of that co-management?
Working to get a flow chart or a flow scheme for an individual patient would probably be the way, and if that came to be complicated or not working well, that would be a time to refer back. I think the general idea would be for the PCP and the specialist to work together to look at a trajectory a few years out. That segues into the transitional clinic idea, because neither the primary care doctor, if it's a pediatrician, or the specialist, if it's a pediatric neurologist, is going to be managing the patient for all times, and they may continue to have seizures through to adulthood. So along the timeline, it would be also important to think about that. And I think referrals, one of the things that we do in some of the clinics is to have the patient seen once a year, or less even, if it were such that the situation's totally under great control and there's no issues. But if an issue came up, or there was an issue that hadn't been anticipated, that would be the time to refer. Otherwise, I would think for a stable situation, yearly, annual, and telephone calls or communication in between time to manage and co-manage if there's an issue that can be dealt with. It doesn't require bringing the patient in.
Okay.
And that really helps us to think about when you're talking about healthcare transition for teens and young adults. Is there a recommendation for primary care in terms of should they begin to establish a relationship with an adult neurology provider prior to that patient leaving the pediatric care? I mean, which should happen first? Which transition should happen first?
I don't know the answer to that. I do know that I recently came upon very nice guidelines published by the AAP, the American Academy of Pediatrics, about transition in general. This wasn't with any specific diagnosis, but they talk about starting at age 11 or 12, and the whole notion of transferring, increasing responsibility, awareness, letting the child increasingly run the appointment, and having the parents sort of either excused or not come in at all at a certain point. And I think the same would apply to a chronic condition like epilepsy, in that some parts of that planning start really early. I think the establishment of care with an adult provider would probably be around the same time. I'm not sure there's any advantage to seeing an adult neurologist before transitioning to an adult doctor for regular primary care. But I think that would be individual, and to see what resources are available. I think if it's a 2-hour drive to come here and it's a 17-year-old who really is already either driving or not interested in coming in and stable, that would be a good time to start to look for local care for the neurology part of it, and may not transition till after college from the primary care. Mm-hmm. But it's individual. There's a lot of play in that.
And we don't have any more formal questions. Is there anything else for primary care providers that you think we haven't hit on?
I would think the part I'd like them to know is just to befriend epilepsy and know more about it. And the way to easily learn more about it is to be aware of all the resources that are out there. And I would start really with the Institute of Medicine report, which is dauntingly long. It's 500 pages. However, it's a nice guideline and a map for all of us who treat people with epilepsy or who manage people with epilepsy. And I think the considerations in the first few pages, the overview, the background, is a nice exercise to go through to sort of say, okay, this is what I need to be thinking about, and this is the consideration for care of a person with epilepsy. And then you just start to assemble the various resources in the community and beyond to help take care. And I think there's a lot of other web-based information and websites that are really valuable resources to be able to give to families and patients, and again, just raise the general level of awareness and education about it. So even if you personally don't know it or haven't dealt with it, there's still a nice way to give parents and families access to resources, or just education about the whole diagnosis.
Great. Yeah. Thank you very much.